Good morning, everybody. It's a lovely autumn day where I am speaking to you from in Canada. I'm Deborah Baker. I think you've seen me on the platform previous to this, and I am a steering committee member for CLL Advocates Network, as well as a member of the CLL Canada board. I'd like to introduce you to our panel for today. You've also met all of them before. First, we have Charlotte Martin. Charlotte is the Patient Advocacy Manager at Leukaemia Care in the UK. Raymond Vles is the Chair of CLL Canada, the CLL Canada Board. He's also a co-facilitator of a support group for CLL patients in the Montreal area, and he himself is a CLL patient. Michael Rynne is a founding member of CLL Ireland. He's also a member of the steering committee of the CLL Advocates Network and the communications officer at CLL Advocates Network. And Michael is a carer. His wife, Jan, is the one who has CLL. So we're going to be talking about health technology assessment today, and it's become an increasingly valuable tool to examine the effectiveness, quality of care, patient outcomes, and cost effectiveness of healthcare technologies. It's been used for more than 25 years around the globe. Argentina, Brazil, India, Indonesia, Malaysia, Mexico, and Russia use it, Israel uses it, and the countries best known for their comprehensive HTA programs are Australia, Canada, and the United Kingdom. So when we talk about HTA in terms of patients, we're talking about pharmaceuticals, but there's also HTA for equipment and machines, as well as procedures and physical techniques for health prevention and promotion. I've been involved with CLL Canada and the CLL Patients Advocacy Group before that, and we started preparing patient submissions in 2012 for the drug bendamustine. And over the next probably 4 or 5 years, we did up to 10 to 12 submissions. So CLL Canada, because Canada had such a comprehensive program, were involved from the early start of when it was available to patients. And Raymond, maybe you could just give us a little indication of your involvement since you've become the chair of CLL Canada.
Okay, well, when I came on the board, we were involved in partnership with another organization called Lymphoma Canada. We were preparing the HTA for the submission for venetoclax and acalabrutinib. Venetoclax first line and acalabrutinib first and second line. And so I participated and commented on the questionnaire, and then I participated in writing up the submission. And I more recently that's a bit strong a word, but anyways, facilitated a group of patient groups doing a submission on a drug for a GVHD, graft versus host disease, which comes after stem cell transplants, which affects many blood diseases. So that's been my involvement in it, and plus I have a bit of a background in doing questionnaires in various ways, shapes, and forms.
It's good to know that CLL Canada is continuing the process.
Yep.
Charlotte, can you give us a bit of background on your involvement in HTA with Leukaemia Cares?
Sure. So I have been involved with Leukaemia Care for 3 years and have been working on HTAs for the whole of those 3 years. But our involvement as an organisation probably goes back another 3 or 4 years to about 6 years or so. We actually have made a commitment over the last few years to be involved in every leukemia drug appraisal by NICE, which makes decisions for England, and also SMC, which makes decisions in Scotland specifically, because healthcare is done at a country level in the UK, for those who don't know. And we've made that commitment just because we feel that it's the most important step in terms of the UK healthcare system is to get treatments funded on the NHS. That's the only way that most people will be able to access those treatments. So that's why we've made that commitment, including CLL tumours, but also we cover all sorts of leukemia types. So we try and get involved in every HTA we can.
That's a huge mandate to,
it certainly
provide
is.
submissions. Yeah, a huge amount of work. I know that CLL Canada only does CLL relevant submissions, but Lymphoma Canada is involved in doing every submission that's related to leukemia and lymphoma patients. So it's big. Michael, you're new to the HTA world. Can you give us a little bit of background on what CLL Ireland is doing now?
Very new to HTA, and I suppose from the day that we started advocacy and watching how difficult it was to get drugs approved in different countries, we always knew that someday that we'd have to get involved in this process. I suppose there was always a fear that did we have the capacity within our organisation to do this work, but a call came in earlier on this year from the organisation that makes these decisions. It's called the National Centre for Pharmacoeconomics. And they reached out to a patient group to get patient experience. And obviously we're a patient-led charity for CLL. So we started the process of, they had a template, and we started the process of filling in our first HTA. We were quite fortunate because of the involvement with CLL Advocates Network, able to reach out to Nick York to find out the survey results from Canada, from the UK. We did our own survey, so we started to get a strong submission. Within our group, we were quite fortunate that a patient advocate stepped forward that had a great skill set for actually putting that together, which we'll speak about maybe further on how we found the process. But I suppose this year is our first one, so we're quite happy with the results, which I'll tell you later on.
Congratulations, because it can certainly be a daunting experience looking ahead. So you were able to collaborate with other groups to get patient data, but can you maybe give us a little bit of information about how you collected your own patient experience?
Well, actually, I have it. I printed off the submission before this meeting, and I know that when we were talking in preliminary talks with the group here, that I think Raymond had said that his was 11 pages. Ours was actually 19 pages. I couldn't answer that question the other day until I printed it off. But the information for this submission was primarily gathered through CLL Ireland patient experience surveys. We carried out a survey in April 21, living with CLL, where we had 78 responses. But in June 2020, we had also a survey for the impact of COVID on our patient community, and we had 151 responses. These surveys we also combined with the international surveys that we had. We had carried out a survey with Lymphoma Coalition, a global survey of the experience of living with leukemia. And because we had 179 responses, and I think if memory serves me, if you had more than 100 responses, Lymphoma Coalition gave you a country-specific report, which was fantastic. So we'd also actually surveys, and it just shows you the evidence-based advocacy, how important this is. We didn't know at the time, actually, that we were doing some of these surveys, that we'd be using this information for this HTA, but and I suppose that came up at one of the sessions the other day of the importance of doing these surveys. Sometimes you don't know where you're going to be using the information. But I know that these surveys, when we combined the information, it really, really helped the fabric of this particular survey that we did. We actually did a survey also with the CLL Society, which was a limited duration and minimal residual disease study, which actually related completely to the survey, or sorry, to the HTA that was taking place, because it was venetoclax and obinutuzumab, which was a limited duration, and the big buzzword is the minimal residual disease. So the information on that survey also helped.
I think it can be a little daunting for patient advocacy groups to think they need all this patient information and that they have to do surveys, but they may not have the outreach for that. So it's really reassuring, I think, to know that there's other patient groups out there who may have this data for you. Lymphoma Coalition, who you mentioned, is a great source, and they're more than willing to share information, as well as I think any other advocacy group who has this information would be great. And I think, one of the challenges is that because clinical trials are very country specific, you may not have patients in your country that have actually experienced those drugs. So Charlotte, can you maybe speak to that topic about how to find those patients?
Yeah, I think Michael's made some really good points about collaboration already. Like, there are certain things that are always cultural and country specific, you know, that's especially around experiences of the healthcare system. So, for example, NICE always want to know from us whether patients prefer treatment in hospital or out of hospital, and clearly that's going to depend on what care is like in hospital and what care is like if you're going in just for the day. But for things like advantages and disadvantages medically of a treatment, most of those questions are included in international surveys, such as the one that CLLAN is currently running with a couple of other big advocacy networks. So I don't think I have much to add over above what Michael's very eloquently already said. And it's really a case of most charities I know working in these networks like CLLAN are always keen to share whatever they already have, because there's no point in duplicating work. We have a saying in England, I don't know whether it's universal, but don't reinvent the wheel. Just, you know, use what's already available.
I would agree with that.
Deborah, could I just add here that, you know, essentially there are three things that at least the Canadian HD, they ask me for in broad strokes. Say, what's the patient experience with the disease? What's the patient experience with existing treatments? All those things can be gathered by, you know, use existing data. The challenge sometimes becomes what's the patient experience with the new treatment, the treatment under consideration. And I've seen that some Canadian groups, if they can't find a lot of patients, will just do interviews with 2 or 3 or 4 patients, or they'll do a focus group. And the other thing, which is we have done, is we've run the survey internationally. So we posted on forums, Health Unlocked, et cetera, in various places. So that's it can be a challenge. It can be more difficult to get the data on the new treatment, the patient experience with the treatment under consideration.
I'll just jump in. Sorry, I just wanted to jump in to agree with Raymond on that point. I think one of the things we found really hard to collect data on is preferences between time-limited treatments and treatments you take for a long time, and focus groups are just easier to elucidate those really complicated topics. So yeah, just wanted to agree with Raymond, really. Sorry, Deborah.
No, I'm glad you jumped in at that. Charlotte, can you think of any other challenges that you've come across and been able to overcome?
Yeah, many. I think I'll try and keep it brief. I think one of them is time. It's always difficult to find the time to sit down, and we've already talked about collecting the data, but then there's bringing it together and answering the specific questions that you're asked. So, for example, at NICE, we get a template submission where they ask us the same questions every time, and it's working out how to make your point in the most effective way. Writing persuasively is a skill in and of itself, and I think that takes time. Then there's simply things like attending the meetings can be really intimidating. So there's a meeting at both NICE and SMC in the UK where you have to sort of sit there as a patient expert and try and put your point across as to why you think the treatment should be approved. And it's very intimidating, even on Zoom, to see 10 or 12 people in front of you who all want to talk about the economics, and you're there just to talk about the patient experience. And I say just from their perspective, obviously. It's not a just thing from our perspective. It's important, but it's not always considered important to those people. And then the last thing I wanted to mention is about the impact that the stuff you're providing has on the process. Certainly in the UK, it's not clear how all that evidence you're collecting is actually used, which is a real shame, and something that we're working really hard to get better at in the UK is to try and ask NICE and SMC to say to us, you know, how did what we said to you in that meeting, in our submission, actually influence the final process. So that's our 3 bugbears.
Yeah, I can understand those. Michael, can you address that question as well about the challenges that you faced?
I suppose the big challenges, and I've mentioned it already, is capacity within the organisation, and maybe the fear of taking on a HTA, because even the name itself, Health Technology Assessment, so someone phoned you from the National Centre for Pharmacoeconomics and said, we want you to do a health technology assessment, it actually can be terrifying. But actually when we got into it, it's the reaching out to the organizations which I mentioned, and I know Raymond had said carrying out the international surveys, but it actually went so far and so wide that we actually had a well-known patient advocate, Deborah from Australia, and she won't mind me mentioning her name, but she gave a patient submission. So when you're talking, ask me about challenges or barriers, I actually found as soon as we got into the process that there wasn't many barriers. It started to actually click and started to work. Deborah had given us a submission because she was a patient that, believe it or not, travelled from Melbourne to London for a clinical trial for venetoclax. And she shared her personal story, which actually went into our submission. And from that, we also had reached out to the patient community in Ireland and patients. We had some patients on CLL13, which was a trial that used venetoclax, and they gave a submission. And then also there were submissions from patients who wouldn't have been on venetoclax, but just the living with CLL and the difficulties with it. And I have to be honest with you, I actually got a bit emotional reading their submissions, even though CLL has impacted our family lives. I thought I'd kind of seen it all, but when you read the wider patient community and the difficulties, I think that the surveys, one of the survey results that like I have the paperwork in front of me, is when considering new treatments, 99% of patients and 80% of carers in the Living with CLL survey indicated that it was extremely important to them to have an alternative fixed duration treatment other than chemoimmunotherapy. So sometimes we don't hear what the patient actually wants. I know we can look at all the data, and we hear earlier on that there is still a role. I know I'm maybe going off subject here for chemoimmunotherapy, but it's to know what the patient wants. That maybe the patient, even though the patient may do well on chemoimmunotherapy, if the patient doesn't want it, they need options, and them options are there, and we need to get the access to the drugs.
Yeah, Raymond, could you maybe address some of the challenges you've encountered?
Well, I think a lot of them have been mentioned, but I guess what it's always you're giving patient evidence, and everybody else has studies and reams of scientific papers and things like that, and economic studies and economic analysis, and you can sort of feel like you're in left field. We don't get to meet the committee, unfortunately. We give a paper submission and don't get any feedback other than the recommendation. So that's a bit difficult, but. What I always try to remember is, the role of HTA is essentially to determine what's the value of this with respect to the cost of it. What's the value of the treatment with respect to the cost? And so patient quality of life is one of the big parts of the value. And that's what you're bringing out. And since we have to fit in a sort of scientific kind of paradigm, you have to have some quantitative data, some tables, and explain your methodology, et cetera. But then you also need to bring out the human side. And so you want to use patient quotes, for example. And so that so you have to sort of balance the two. And you also, since these people, I suspect that they have lots of reading, we have to make our submissions very easily readable. And we've been experimenting on the latest one with pie charts. You take some of the data and you put it in Excel, make a little pie chart and squeeze it in. And that makes it more reasonable. And I use section heads with titles, and then I use the summaries at the end of each section, a couple of quick one-line bullet points to summarize. So if somebody's skimming through the submission, they'll get the main headlines. Now, I think a bit of news media reporting when I'm doing this, and to really try and get across what we're talking about is the value, and the value to patients, and in particular, obviously there's survival, but there's lots of data on survival in the studies. It's the data on the quality of life that doesn't exist in the studies. So how does it affect your family life, your family, your work plans, your intimate life, your et cetera, et cetera, et cetera. Anyways, I've gone on too long already, so.
No, you haven't. I think you brought a lot of good points up. You're right that the committee members have read a lot of information and they may not be familiar with CLL. So it's really your job, as patient submitters to give them that information. I think the use of charts and definitely the patient quotes and even caregiver quotes, if you're allowed to provide caregiver information is really valuable for those teams, because I know, looking at the makeup of the committees that assess the drugs in Canada, there's a hematologist and there's a patient representative on it, but that patient representative doesn't know anything about CLL. So, you know, part of your role is to make them aware of it and really give them an insight to the patient, how they're feeling, and as Michael mentioned about, you know, long-term therapy, chemotherapy versus non-chemotherapy. It's very valuable for them to know that, and I really feel we teach them a lot. One other thing, if we've touched on a little bit, is how do you collaborate with other groups to extend your resources? I know that you do that with another group, Raymond. Maybe you could just give us a little more information on that.
Well, I guess when I came on the scene, that collaboration was established. So one of that submission, I just worked really directly with the person at Lymphoma Canada who was writing the submission, and we went back and forth on drafts. I mean, she was the lead author. And then the second case, where we were a bit of a coalition of groups, I guess I ended up sort of this facilitator and we had some. It was during the pandemic, so Zoom calls were easy to arrange, and so we got everybody to submit or to pull together questionnaires, and so we were doing a survey. So we had a whole list of questions, and we went through them and discarded some and kept others and modified some other ones. So that we went on a couple of calls to get a questionnaire, and one of the groups then put it online on SurveyMonkey, translated into French, since that's to be 2 languages here. One of the organizations managed that whole process. And then for the writing of it, I guess another was Lymphoma Canada took on the role of lead author. And some of us, I guess mainly myself, sort of commented and made suggestions and helped with the visuals and the readability. And then we submitted. So it was a bit of we invented the process as we went along, shall we say, based on who was involved and who was willing to do what.
Yeah, and I think that's what happens because the processes change as well. We have a question that's come in about how to make the best use of collected data in relation to the lobbying that associations try and develop for the benefit of patients. Who would like to tackle that one? Charlotte?
I assume the person's referring to sort of other data they've collected for policy purposes, like influence decision makers, if I've interpreted the question correctly.
I think so.
In which case, I guess a little bit of advice, if you like, from me, if it's not too bold, but is use whatever you've got. Like I said earlier about reinventing the wheel, if you're planning on running a survey at a particular time for a particular reason, then consider expanding the survey if you've got a HTA coming up, or you think there may be one, you've had a feeling from a pharmaceutical company that it's coming along fairly soon, and combine the efforts, because I don't know about everybody else, but I cannot stand multiple surveys. Nobody likes an extra long survey, but if you're going to send one and then 2 weeks later send another, then make it one survey. Preparing in advance, I think, is one of the key things you can do for HCAs is to think be a bit more strategic in how often you speak to patients and what you're asking them when, and obviously feeling out who else is doing what. So there's an international survey running, then be wary of that as well. Be strategic as possible would be my advice.
I think I agree with you totally, because we've often talked about survey fatigue, and that was in the early days, and now there are just so many more surveys that I think people are really getting tired of them. Another question is,
if I could just
go ahead,
here. I would say, whether you're writing an HTA submission or lobbying, you're telling a story. You're telling a story that's based on data, and it's as solid as possible, and using quotes and using information. But always think you're not just presenting a scientific paper with data in it. You're telling a story, and your story has a beginning and end, needs summary points, and think of it in that way. Think of it using the data in that way to tell the patient story, and bear witness of the patient experience.
I think that's a really good way to look at it, Raymond. That's exactly what you're trying to do. Yeah, Michael, do you have anything to add to that?
No, I completely agree. I think that I think that the benefit of actually of working together, I think looking at an organization is to widen the people that you have. Sorry, getting back to survey fatigue, there was actually a point I wanted to make. I took it down about survey fatigue. That is one thing we're always concerned about. I named all them surveys and all, and actually when we were doing this HTA, one of the concerns we had is that it came up and said, well, actually we better run a survey, and we were saying, I think we had only done a survey, but what we actually did was we explained to the patient community that what the survey was for, and we had a good response to it. So I think that's a survey fatigue is the big thing, but how else do you collect the data from the patient community,
Yeah, may I just jump in there, Deborah? Sorry.
Yes,
just
please.
On the point about Michael was making about explaining the point of the survey, I find it also important to tell patients the outcome afterwards, and importantly, how the information they gave you, as much as you can, because I complained about the fact we're not quite sure how it does at the beginning, but as much as you can, how that influenced the decision. But you said this is what the committee said, you said this is what happened in the end, and that really helps the uptake of our surveys, because people realise that we're not asking for stuff for the sake of asking for it. It has a purpose, it has a use.
The first sentence on our promotional email in the last survey was, the very first sentence was, help Canadian patients gain access to a treatment for GVHD. Right up front, right? Very first sentence.
Yeah.
I think the message is there.
And do you go back after you've done these surveys and share the results with your membership? Do you let them know that the drug's been approved, or whatever the results are?
We tell them where the drug is, how it's faring in the process.
Yeah, and exactly.
Actually, you do that as well, Charlotte, and you will be doing that, right, Michael?
Well, we will be doing it. Actually, to be honest with you, it's actually a little bit of a frustrating process, because it's like I mentioned, the organisation, the National Centre for Pharmacoeconomics. It's always easier for me to say that, even though it's long, than saying the letters, because when I say the letters, I say them the wrong way around. But we got the news that in August 2021 that the NCPE recommends that venetoclax in combination with obinutuzumab be considered for reimbursement. So it's well on the way to being available for patients, but it's not there yet. It still has to go to what's called the corporate pharmaceutical unit within the HSE. So you're waiting for the people in the offices to make the decision on it, which can be frustrating. So we can't tell our patients it's going to be next week, it's going to be next month, it's going to be January. And I suppose when you talk about the barriers, that's the frustrating part, that you still feel that somewhere along the line, if someone is dragging their heels, that you're going to have a campaign, even though you've done all this work on the HTA, and you know that the HTA is strong, and you know there's value in that treatment to be made available to patients. Like, to give you an idea, in Ireland, we do not have any access, frontline access to any novel therapy, unless a patient has a P53 deletion. And in 2021, that's actually shameful. And because we have Northern Ireland that's connected to the UK, I think they have 3 novel drugs now that have been approved in the last 12 months. So on the island of Ireland, we have 6 counties up the north that have access to novel therapies frontline that we don't have down here in the south. And I suppose that's a strong statement in itself for when you're lobbying politicians, and I suppose mentioning a barrier earlier on, and I'm sorry for taking up the whole time, but one of the barriers is that our drug approval system hasn't modernized to the modern medicines that are now coming down the track. It's not working fast enough. It's still a slow process. Even during COVID, it didn't seem to matter to patients having access to these novel drugs that would have been helpful. So sorry for taking up so much time.
No, I agree with you. And I think the HTA process is only one step, probably not the first step, maybe the second or third step in accessing these drugs. And it's, a year or 2 before these drugs actually can get paid for within the country, depending on your country.
Deborah, if I may, I don't know how it is elsewhere, but in Canada, as drugs go through the process, some pharmaceutical companies will supply them. Yet the doctor has to ask. There's often a support website, and the doctor makes a request, and they will supply even the drug, even free of charge. So I guess every company has its own sort of system and rules, etc., but it's something to look into.
Yeah, that's right. Well, we have a couple of more comments and questions here. We only have 5 minutes left, so I'm going to start wrapping this up. But someone has made a comment that patient at times may not ask as they feel a bit shy or may feel that what they say is not of relevance. But once someone starts the conversation, then it really helps them speak. So surveys do help in tapping those unasked questions, which really play an important role during the course of their treatment. Another thing I would just like to cover is somebody wondered if there was an overview of what the systems are in different countries and how we can learn from each other. And, you know, we did find when we did our survey that 21%, I believe, of respondents are actually doing HTA, but another 28% said they want to do that. So again, that is something that's going to be on CLLAN's plate to evaluate a little bit more and see how we can take part in that process or help you in that process. And I know that within the CLLAN membership, there's many groups that are doing this now and would be more than willing to share what information they have. And not forgetting that every country has their own little system, as you've seen from this presentation this morning. And
I suppose, Deborah, we could look at maybe like even like the European Union, that all the countries are connected. It would be great that they had the same kind of template, you know. That's maybe something that patient advocates can work towards.
Yeah, I agree. And another good comment is that they wish people making economic decisions understood the plight of patients. But that's what these HTA assessments are for. And that's why it's important that if it's available to you in your country, you should be doing it. Seek help. And as Charlotte said, don't reinvent the wheel, because you don't have to. But just make sure if you've got the opportunity to present the patient side in your country, that it's something that's really important for your patients. And there are resources around the world to help you do that. So I'd like to thank our panel. You've really brought some really good points to this discussion, worldwide points, so you can see that it's something that maybe you can do in your country. Michael, Raymond, Charlotte, thank you so much for your participation in this panel. It's much appreciated.
Sure.
And I'd like to now introduce our next speaker. Nick York will be back, and everybody knows Nick. He is our chair of CLLAN. He is a patient advocacy healthcare liaison officer at Leukemia Care. A patient himself, he was diagnosed in 2009, and he continues to live well most of the time. This stressful conference has been hard, but he's managing his CLL with BTKI therapy. And he's very involved with the clinical group, a member of the UK Clinical Trials Research Subgroup, and a member of the UK CLL Forum Executive Committee. So I'm going to pass the baton over to Nick, and he's going to be talking about more results from our global survey. Thank you, everybody, and have a good day.
Thank you, Deborah. It's a pleasure for me to be able to share with you as the CLLAN Steering Committee Chair some initial insights and observations leading to recommendations from the global CLLAN survey of organisations supporting patients living with CLL. I think a good thing to start with would be what's been affecting us most, that's been affecting our patients most, and is likely to going into the future. And as organisations supporting our patients, we have been massively impacted and responded very, very well and very quickly to be able to meet service needs. This talk isn't going to cover a great number of the unmet needs and recommendations. Time doesn't allow, and to prevent a whistle-stop tore through. I think we're just focusing on a few key elements. So if we start with COVID, and if we look at how COVID's impacted on access to support services, working from the returns of those that participated in the survey. If we looked at support services that were reduced and stopped, just over half, that's 53% of organisations that had to stop or reduce any of the support services they provide to CLL patients because of the COVID pandemic. And we know there are several reasons for this, and we've been discussing that during Horizon, so I won't go into the detail of the whys, whats, and whens. If we look at support services that were adapted, I think this is where we performed really well as a network of organisations. Nearly 3/4, 72% of organisations reported having to adapt some of their support. And now this is an ongoing situation. It's not just one moment in time. At the time of the survey, this was taken. I think we can pretty much assume that this is the case still today. What is interesting is that engagement with patients during the pandemic, in the past, maybe less now. Obviously, we'll have to get feedback from all of you on that. But over a third of organisations reported that CLL patients who were already engaged with them made more contact during the COVID pandemic. And just under a third of organisations said that more CLL patients contacted them for the first time. Now, we don't know at this moment whether this is due to the fact that we'd had to digitise services and we were more reachable and we're reaching more, or is it because healthcare professionals and other means of information and support were not open to patients and that patients were more in distress, so they were reaching out to us? But it's an interesting observation. So we've been doing a lot more with less. If we look at funding and fundraising, we know that organisations are already challenged with funding, and many are underfunded and rely very heavily on volunteers. And if we look at organisations that were asked of the overall impact of the pandemic on the ability to secure funding, 2/3 were impacted negatively. And only a very small number of organisations, 3, managed to experience a positive impact on funding. So we're looking forward to learning the lessons from our network members who have managed to achieve this. The second slide looks at perspectives from respondents as to patient experiences with regards to access to their healthcare and treatment during the pandemic. And if we looked at treatment, probably this is during the peak of the pandemic, nearly 45% of organisations said that their patients had reported that there was a treatment delay. And over a third, 38%, said that their CLL patients had reported changes to treatment. Now, I think during the conference, our clinicians will have been able to explain much of this and what the situation is going forward. But it'd be interesting that we've managed to learn what the policy is moving forward, as the pandemic is still impacting massively on patients. In-person activities are curtailed, and much of the activities, as it says here, just under 2/3, 61% of organisations said that their CLL patients' appointments had been postponed or cancelled. 2/3 said that their CLL patients reported cancelling their in-person appointments, which means remote appointments have been taken up more broadly now in terms of healthcare provision. And just under 2/3, which is a considerable amount, 64% of organisations, the patients are reporting now that appointments are being made and consultations are by telephone or video conferencing. And with the pandemic still causing this impact on how service delivered, this looks like this is something that's going to be moving on into the future. So we need, as a network, to look at how we address this to ensure that network members and organisations are providing the right support to the patients that are under their care. Clinical trials, that's an interesting one. Because of redeployment of staff, clinical staff, and because of the overload in hospitals, many of the clinical trial services had to be stopped. Recruitment had stopped, and of those that said clinical trials had been stopped, 91% said that now recruitment had started. And I think if we're looking at that, those are in countries where the pandemic isn't peaking in terms of hospital admissions and impact on the staff. But I think one that's really interesting, and we put this here in a bold highlight, over 3/5, 63% of all respondents, so out of 57 who responded or felt they could respond, 63% didn't know the status of clinical trials. Now, we need to just explore this further. Was this a moment in time, or is this actually an observation of awareness within the network of organisations that responded to the trial of status of clinical trials in their countries and what's available to their patients? This slide looks at how many organisations had adapted their services during the pandemic, and I think the red says it all. And there are some striking ones in red. There is variation by region. It seems that in North America, everybody there clearly had to make, I mean, there are 6 respondents had to adapt. So if we look at this, nearly 3/4, 72% of all organisations reported having to adapt some support. And I think we know from our own practical experience, having had to digitise many services, that's the only way that we could deliver them. And that's the only way we could maintain the support and contact with patients and educate, and also help with navigating many of the uncertainties that's been the case. But it's interesting where such a significant number haven't. Now, whether that's down to resources on the ground, infrastructure to be able to maintain digital connection, or level of infection, societal change, or if they already had a lot of digital connection, digital service delivery in place, we need to explore this a bit further. But I think overall, what we need to do is perhaps give us all a pat on the back, and that's everybody. I mean, it's incredible the amount of speed and the speed with which everybody switched over to service delivery to maintain their support for their patients. So I think you know, well done, everybody. And this is now an ongoing situation. We all know that we had to do a lot more with less, and it was a constant crisis with misinformation, lots of uncertainties, constant contact to advise patients on how to keep safe and how to get the support they need in an environment where they're totally isolated. So if we actually look at support service provision during the pandemic, looking at the chart on the right, I think that clearly shows that that's very top heavy around information. So the information demands have been massive, and it's been a moving target with massive uncertainty. But it's also reassuring to see how many organisations have also managed to adapt or change their service delivery model to be able to incorporate conventional support and support activities by extending resources, looking at new helpline facilities to cater for this, and increasing capacity in existing services. So again, I think that's a well done to everybody, and we're looking forward to learning from the experiences of you all. Now, this slide addresses an interesting question. What materials do you not provide but would like to? And coloured in blue, you can see those that are digital related. So again, this kind of adds to the digital move at the moment and the need of patients and the need of organisations to be able to cater for those patients. And I think if we just make a mental note looking at these, you know, app, video, but app is very clearly sitting at the top in terms of what people would like to provide and currently don't. And I think as we go forward into the next slide, you'll get an idea of some trends that are emerging here that are actually justifying prioritising of a few unmet needs. So, as I said, most common digital material development is the requirement. And I think if we combine this, as I said, with the data, this is further evidencing this needs to be a high priority area to help network organisations and for CLLAN to work to help provide resources and initiatives to help people deliver these. I know we're challenged because, as we touched on earlier, income, limited resources is a challenge for many organisations, but we've got to work creatively to try and find ways around this. But something that did pop up that's quite interesting in this chart there. 1/5 of all respondents would like to provide printed hard copy information. I found that quite surprising. I think that's something we need to look at further, whether we can, you know, look at ways and initiatives to enable, you know, delivery for these organisations, because not all CLL patients, not all people are digitally savvy. So, you know, with switching over to digital operations and more digital, we are potentially actually keeping those people that are not digitally aware isolated. So we need to make sure as organisations that we do maintain traditional methods of information delivery, even if that's using old-fashioned methodology, the post. So I think just in summary, one of the key areas, this summarizes digital development as a key priority area. We can see from what I've just been saying that there is a gap in digital service provision across the network at the moment. And the surveys confirmed that there is effective use of digital support materials for patients by the majority of organisations. And the pandemic's accelerated, as we just said. And printed materials are still not provided by the significant number. Now, there's a clear ongoing need for continued development, because the pandemic's not going away. CLL patients are one of the most affected immune-compromised groups. There's a considerable amount of uncertainty and safety, and it's very likely that to maintain contact and the appropriate support with organisations, this needs to be an ongoing development process. So we need to build this into not just a short-term strategy plan, but a long-term strategy plan. Now, as an action on this plan, I will continue to develop our website and our resources and abilities in the area of digital delivery. The survey has identified your key priority areas that you wish us to focus on. Some of that has actually informed horizons. And most importantly, we need to work with you as a network to explore lessons and barriers that you as members are experiencing to help us develop together support strategies that are meaningful and relevant to your location. And I think one of the things I highlighted earlier was, amongst looking at innovation, the highest requested item that people don't currently provide are app-based services. And there are organizations within the network that are successfully using apps. And I think this is information we need to share and work with stakeholders to find out what is the most appropriate. In countries, we're working with the clinical communities as well to implement these into day-to-day healthcare. So this is something that we can't leave standing by now. If patients and their families, those affected by CLL, are isolated, they need immediate contact and they need to be able to get feedback. So this is something that we are suggesting is a priority area for exploration. So the next two charts, they're interesting, and I'll flick backwards and forwards between them. So the first chart here emphasizes what services you do not provide but would like to provide. And highlighted in pink there is a reason for these, because I want you to be able to see where they sit in the chart of what you already do provide. But if we look at services, and obviously this is a session in the area of access, a clinical trials directory is sitting at the very top. 42% would like access to more information about clinical trials for the organisation and for their patients. And again, interestingly, around access, which is the main gist of these sessions, 28% of respondents want access to information how to become involved in health technology appraisal, to encourage access to new drugs and the process. And the session before my talk has been covering that. So hopefully this has addressed many of the questions and answers you've got in that area. And they're highlighted for several reasons, because the next slides were like that. Fundraising resources are very high up in the list for many obvious reasons. But I think we have problems when we look at how that's delivered. So that's something the network is looking to work to help empower our network members and other organisations. And I've just flagged awareness campaigns that'll come to light when we look at the next slides. But that's sitting somewhere in the middle of the table in terms of a request of what people would like to provide. And that will be eluded when we look at what people do provide. Awareness campaigns are very high on the very top, it's nearly the very top of services provided by the very majority of organisations. Obviously, patient support, education, telephone support, CLL news, traditional forms of information are sitting top. It's really encouraging to see now that 61%, 35 of you are actually reaching your patient groups digitally by webinar. But I'm flagging awareness campaigns because that will come clear in the the next slide. But again, fundraising resources. We know how underfunded everybody is. We know the challenges that we have at the moment with COVID, with in-person activities being a little bit limited, in some areas non-existent. So therefore, if you rely on that for fundraising, heavy dependence on single funding, quite often from industry. And again, services provided by organisations, very few provide services related to health technology appraisal or are involved in the process. And this is something we need to change together. And sitting right at the bottom, clinical trials directory. Very little information is provided by organisations around the globe for patients in access and understanding what's available in clinical trials. What are organisations doing well? Well, question 8 in the survey was an open-ended question, and a thematic analysis actually coded everything to be able to grade what your organisation is doing well. And looking at responses, 2/3 of organisations responded to the question that they're doing well with support provision, which is great to hear. Whereas fewer feel they're doing well with information material provision and education. And hopefully that's something we can actually address when we're looking at digital delivery strategies and helping empower with how you can provide the information you need to. But I think what's really shocking, well, it is for me, strikingly, only 19% of organisations feel that they're doing well with advocacy. Now, we're all here together as an advocacy network, and we're going to have to work a lot harder in this area, because, for example, raising awareness sits in that as that's part of campaigning and advocacy. And advocacy and campaigning are very key towards the addressing equity of access and actually pushing for access to new treatments and appropriate care. So the main reasons I touched on earlier across all regions for non-delivery of services was a lack of human and financial resources. This is something we all experience and something we also experience as CLL Advocates Network as we rely on working with network members to deliver our services. So I think we need to work as a top priority to look at exploring successful fundraising and campaign and advocacy in our priorities and initiatives that come out of our strategic planning. Moving on to clinical trials, I brought this one in because obviously access to a clinical trials directory and understanding of clinical trials has been flagged and highlighted in earlier questions and returns. And I think if we look at this question here, do you think your patients have got enough opportunity to take part in clinical trials? I think we can clearly see here, looking at the no's, and yes, to some extent, that there is not great opportunity, hence a reason we need to get more involved in advocacy initiatives, health technology appraisal or assessment, sorry, is the right term for that, to ensure that there is equity of access, and we are pushing for appropriate treatments and trials in countries where there are not. So nearly half of respondents, 47%, don't think CLL patients in their country have enough opportunities to take part in clinical trials. So winding up on clinical trials is one of our key observations. As I said earlier, 42% of CLL supporting organisations report that they want the clinical trials directives as a priority. And we touched on earlier, there's an issue around awareness and access. But we have a problem. I mean, creating a clinical trials directory is complex, it's challenging, it's not sustainable. We've talked about this through many years of how we can do this, but there is an opportunity for CLLAN to explore creation of a signposting resort that would be web-based and we could host on the website. And we discussed this as a steering committee. We've had access to some of the early trends coming out of the survey, and we've been working in our preliminary discussions. We prepare our short-term and long-term strategies. But before we move forward with that, we need your engagement and your involvement. So we are already exploring producing a signposting service, and that would be hosted on the CLLAN website. And that we're looking at ways we can link. We don't want to reinvent the wheel, but we'll link to existing service and gather information from existing search databases, linking in to make sure that we can provide information. As one of the most powerful, which is clinicaltrials.gov, but there are many regional databases in different parts of the world. And I think, as I touched on earlier, we need to develop advocacy initiatives to raise clinical trial awareness and advocacy involvement. So let's just look at a broader brush. Next steps with the survey. The full survey report will be finalised in due course. The analysts, and it needs a lot of work at the moment to identify the key recommendations and then prepare for publishing and circulation to all of you as participants, and publishing within the clinical community and the broader community to help with awareness raising and understanding. CLL Advocates Network, we will formulate a strategic plan to address all of the key issues that are coming from the survey report. And these strategies and recommendations are going to be a core part, using these unmet needs to determine the network priorities. And as I touched on, we've already had an initial strategic planning meeting, and towards the end of this year, we have the second phase of that. And in the new year, we'll be finalizing that with a long-term strategy. And part of this is we need to not just develop global, but we need regional and more local recommendations. And to do this, we need your engagement, and we need to work with you. We need to bring focus groups together from the community to tackle specific unmet needs and recommendations and solutions that are relevant to you. What I would like to say, we're already well underway with part of this empowerment in terms of we are already building a global directory of CLL support services, and this is being hosted and will be hosted on the website, the framework, the infrastructure, and that's being populated. And that's being populated by your very detailed returns of how you provide support to patients in your countries. This could become, and we hope becomes, a go-to place which will actually help people. It's searchable by location, by many different ways, and will enable people that don't have resources to be able to find resources in the same language or in their proximity in their country over a border, that kind of thing. So we'll keep you updated on all of that. And I'd like to just wind up by emphasizing, to deliver all of this, we need to expand the network capabilities. And, the survey is developing clear unmet needs. Great. Now we need to deal with them. And it's also identifying your strengths and weaknesses. So we're looking to develop opportunities to work with you as network members to extend these capabilities and aid capacity building in key areas in your countries that have been developed by the survey returns. And to do this, we need more involvement, and we need to involve you more as members in the network. So first, the survey has identified this, out of 57 participants, we can see clearly there that we have 31 members and we have 26 non-members. Most non-members have said in the survey that they would like to join the network. The survey identifies the benefits of the network and also the capabilities of organizations within the network. So please do get in touch, use the email below, and follow up with Nicole and join us, because together then we become a stronger force, and we will, we can combine our knowledge. I think from a CLLAN, CLL Advocates leadership point of view, we now need to include your involvement as members from the top down. We need to extend the capabilities of the steering committee from a governance point of view. We need experts in different areas and disciplines, in professional areas, as well as expertise and understanding of delivery of advocacy and healthcare and patient support in your countries. Most importantly, though, to make any outputs from all of our work and in the strategy, we need project working groups with you as members partaking in these with us, and we're going to need to create local focus groups to shape and develop these future initiatives and regional priorities. So please, if you're interested in being a member, or if you're interested in being involved, please contact Nicole on the email below, and please do enjoy the rest of the conference. I think we've still got some way to go, and I'd like to just thank you all for listening.
Thank you, Nick, for that comprehensive review of the survey results. As you can see, or as you've told us, CLLAN has a lot of work to do, and we hope with the help of our members and perhaps some new members from those who responded to the survey and are present at Horizons but are not currently members, we'll be able to fulfill all the wishes and help our group expand and grow. And now I would like to introduce Natasha Bolones. Natasha is a cancer rehabilitation specialist and also a UPATI fellow with significant experience in patient advocacy, patient education and service provision in the field of cancer. She is currently the Global Alliances Manager, regional manager for Europe for Lymphoma Coalition, and she's based in Spain. So I'm going to pass it over to Natasha now to lead the Add Your Voice, and hopefully you'll enjoy the input we have from a variety of advocates. Thank you, Natasha.
Thanks, Deborah, for this lovely introduction. Today, I feel honored to be with 7 brilliant patient advocates. So I'm happy to welcome Liselott Eriksson, Director of Scientific Affairs from Blood Cancer Förbundet, the Swedish Blood Cancer Association, Sweden. Mark Oldland, Chair of Trustees, CLL Support from UK. Dr. Brian Kaufman from CLL Advocates Network Steering Committee, and also Executive Vice President and Chief Medical Officer of CLL Society from US. Leah Corren, member of the Board of Directors, Flood of Light, Halil Haur from Israel, Dr. Yervan Hakowian from the Armenian Hematology Association, Head of Hematology and Transfusion Medicine Department at the National Institute of Health in Armenia, Yana Peluchova from CLL Advocates Network Steering Committee and co-founder from CLL Advocates Network, and also President of Diagnosed Leukemia from Czech Republic. And finally, Raymond, Vles, Board Chair from CLL Canada. I'm very happy because we have patient advocates from different regions, from different areas of the world, with many that face many different challenges and gaps. We cannot deny there have been sustained gains in knowledge, competence, performance, and improvements in the ability to provide care and individualized treatment for CLL patients. But we all know there are yet endless challenges that CLL patients face, as well as disparities around the world. So, as we have 7 panelists and only 45 minutes, I will jump directly into start asking questions. And please feel free also to send your questions through the tool that we have available, so the audience can also participate in this panel discussion. In terms of what the remaining unmet needs are for patients with CLL, I would start telling that there are several novel agents that have been approved by FDA and the European Medicines Agency. However, patient access variability is huge at global level. And how is this in the Nordic countries? Liselott, could you please tell us?
Well, I would say we have access to a lot of treatments in the Nordic countries. However, we are advocating to get access in the prior lines of treatments. Usually we have access in the later lines of treatments, but I would say also a difference from country to country, but anyhow, there are a lot of clinical trials going on, and that's a good way, of course, for patients getting access to new treatments and so on. So, yeah.
Thank you. And knowing that nowadays we have a lot of targeted therapies and innovative treatments, precision medicine plays a pivotal role in the treatment algorithm for CLL, since the integration of molecular biomarkers with the clinical features of the disease that at the end guide the treatment choices. How does it look, access to diagnosis in Armenia? Yervan, you are mute.
Thank you, Natasha, for question. You touch our painful part, because the diagnostic, one of the black hole in Armenia in hematology field. We have a great success during the last years, but we have many problems in diagnostics. Especially for CLL patients, we have a great problem with genomic and molecular testing. But it's nowadays is very important, because only having the whole picture, you can choose the target therapy and specific therapy for each patient. Even in many situations, we can choose watch and waiting tactics. And knowledge of this part of diagnostic is very important. That's why we are trying to go in this direction. Now we have a problem with phenotyping. We have good machines for genomic and molecular testing, but the price is problematic, and we're trying to push the government to pay for patients. I think the coming years, and thanks to have a patient organization at least, we can move in this direction and solve this problem for our patients.
Thank you for explaining that, because I know you have insisted in the lack of patient organizations in Armenia. So, and that's why CLL Advocates Network and all the networks are so important, because from the network we can support other countries that do not have the local resources yet. However, it should be our duty also to help to establish patient organizations everywhere, so patients could have access not only to diagnosis, to treatment, but also to support and to other services that are very well provided by patient organizations. Jana, I'm afraid that since last year we are facing many new challenges because of the COVID pandemic. How COVID has affected CLL patients, and I would love to listen how it was in your country, in Czech Republic as well. Jana, you are mute.
Well, indeed, because of the centralized hemato-oncology care, patients go to the hospital units not only to have their tests on regular basis, but also to pick up for their medicine. It is not possible to get it from a pharmacy round the corner. So there was a lot of logistics issues, especially for those patients who didn't need to go to the hospital for any kind of checkups, just technically to take their medicine. So we managed to get a grant to allow for distribution of their medicines via delivery service, and that was then expanded even more on the whole country. So this was very much appreciated by patients during the hard COVID times, especially patients who don't drive a car, they're elderly, and they had to go by public transport, even change train to bus, and complicated way to get to the university clinic. So this was indeed appreciated.
Thank you, Jana. But I'm afraid that the COVID pandemic brought other challenges, for instance, considerations for managing patients, the lack of a consensus that we lived at the beginning of the pandemic, and especially with CLL patients. This has been a major challenge. Could you please explain more about that, Leah?
Well, the truth is that we spoke a lot about COVID-19 in this meetings, but I think that really the COVID-19 I feel like it was a kind of a revolution for CLL patients. And I think that we considered ourselves more or less healthy. We have to go to the doctors, maybe we have to take a little bit of drugs, but normally And I even remember the first time I spoke to my doctor and I was diagnosed, he said, now you continue to lead a normal life. This is no longer true. The CLL patients now have to be kind of excluded. They cannot go anywhere. They need to have the masks. And now, especially in Israel, most of the people in most places don't need to have masks. So for instance, you have to go into an elevator and there are too many people, so you just stay out and people look at you and say, oh, this is not a very nice person, not going in, or asking somebody to put on the mask because he's too close to you. So I think from one point of view, we had a kind of a revolution. And I think also that people were scared and amazed when they found out that they were vaccinated, but they didn't have antibodies, which happened to quite a lot of our members, especially after the first vaccination and even after the second vaccination. I think we saw the numbers these days. So it was very difficult. I think that the first thing that I would have mentioned was the mental problems that it made to people. The feelings, the bewilderment, the amazement, all the other things. Jana mentioned a lot of the things that happened here. How do you get to hospital? At the beginning, they told us, don't come to the hospitals. And then they said, okay, you can come, but alone. You cannot bring somebody with you, etc., etc. So it was a very bewildering. People didn't know what to do. And I think that many people just froze. Or they decided to live normally, which means like everybody else. And that was another problem. The question, are the directions that the government issues applying to us? Mm-hmm. Now, if, for instance, in Israel now, you can be in a football arena without masks. What about me? If I go to the football game, can I go to the football game? If I go to the football game, can I sit among everybody? If I sit among everybody, do I have to have the mask? Mm-hmm. So it is just a small example. Yes, there are many examples, and it's very bewildering and challenging, and it's not over yet.
Yes, but we don't need examples. We need strategies and harmonized strategies. And I think that probably one of the major challenges has been to develop vaccines, but also making sure everyone who should get them does. Brian, I would love if you could tell us how this is working in US, because I think that has been pretty different from what we have seen in Europe. And not only that, but I would love you also to talk a little bit about the need to have better testing or to arrange better this in the context of CLL treatment.
First, thank you to CLLAN and just enjoying the conference. And I echo I think Leah laid out some really important points that I think are universal. And Jana, applause to you for what you did and respond to a specific need. It just shows how you have to be on the ground to understand what's going on. In the U.S., in terms of the vaccines, like a lot of other countries, but I think we're the poster country for this, we have this anti-science point of view that in vaccines have somehow become politicized. So in late September, Dr. Fauci estimated that there were 60 million Americans who should have been vaccinated who haven't. We have no access problems. You could walk into any pharmacy, and Raymond would appreciate this. Early on, Americans were coming across the border before borders were closed and people could do this, coming across the border and getting vaccines. You just walk into a clinic and, just get a vaccine. It was all and everything was being paid for, which in the US is remarkable. And what's also interesting is more people are getting boosters. Who gets boosters? People who got the first 2 shots, who aren't objecting. More people are getting boosters than people are getting their first shots now because of the vaccine hesitancy. So what this has done is not allow us to get to any kind of herd immunity and allow the virus to mutate and become more virulent, more contagious. So that's kind of been a disaster here. In the informal surveys that we've done, and again, this data is very helpful as we're moving forward, and that's the lectures that we've had on surveys have been really helpful. 98% of our CLL community is vaccinated. So compare that to what else is going on in the US, somewhere in the 60% are vaccinated. So the CLL community, we're the ones who are wearing masks. We're the ones who are vaccinated. So it's been really a different story for us. And I just have to echo, it's no different in terms of the isolation, and people are dealing with this differently. People are taking risks, but they're aware of the risks. But the majority are sitting at home and scared to death about doing anything up to and including hugging their grandkids. In terms of your second question, if I understand it correctly, testing is still an issue. In the US, the issue is not access, it's awareness. So if you're going to one of the university centers, people are aware of the importance of testing, and it's being done, and it's being paid for, and it's relatively easy to get most of the tests. But most in the community, study after study that have been presented at the American Society of Hematology have shown that the testing just isn't getting done in the community. People are not getting tested, and we know that certain markers, as we've learned over the last couple of days, like 17p deletion or TP53 or unmutated IGHV, are associated with terrible outcomes with chemoimmunotherapy in most cases. And so chemoimmunotherapy, if you have other options, should be avoided. But what we're seeing is that's not being done in a significant percentage of patients for the frontline and follow-up therapy. And even in some cases it's being done. The tests show that chemo is not indicated, and therefore, and people are still getting chemo. At the CLL Society, one of our advocacy, small a advocacy, is we have these wristbands, and I don't know if you can read this or not, but what it says is test before treat. And we have it very simple, we say, if you're 17p deleted or unmutated or have TP53 mutated, equals no chemotherapy. We have people wear these into their doctor's visits to remind their doctors of what's going on. So it's a very simple, low-cost campaign that we have working with the patients, but the patient has to know about it and has to have the wristband.
Thank you for expanding so well. And I would like now to move to another topic. CLL patients receiving active therapy must stress the risks versus the benefits of returning to normal activities with or without the pandemic, I mean. But also patients who have completed therapy and have entered survivorship plan or are encouraged normally or want to resume normal activities. But we know that this is not so easy. And if we put this in the context of pandemic, it's even more challenging. What are the gaps and the challenges from your point of view, Mark?
A good point, Natasha, and I'll build on what Brian and Leah has said. It has been a revolution or evolution, whatever you want to say, with the pandemic. It's really hit the community. In the UK, we've got somewhere between 38 and 40,000 CLL patients, about a third on some sort of treatment, either starting, in the middle, or ending. And the game changer for us in the UK was on the 1st of August, when our overconfident, I would say, government thought we were doing so well on the vaccinations that they would lift everything. It's slight variances in between Wales, Scotland, Ireland, etc. But generally, they said you don't need to shield, you don't need to mask, we'll get back to work, get the economy going, and we'll catch up with the rest that haven't been vaccinated. And ourselves at CLL Support, as well as Leukemia Care, Lymphoma Action, all the blood cancer charities got a wave of concern from people either on treatment or in survivorship saying, well, they've had the vaccinations, as Brian says, and very high levels, but the standard vaccines for the vast majority that have called us have been 0 to maybe 20 or 30 antibodies. Now, I've been lucky, I'm on a monoclonal trial as well, and my latest results showed 3,800. So I asked my specialist, I said, does that mean I can go out? And he said, no, we don't know if that's high, medium, or low, and you're on a BTK inhibitor, and you've got other comorbidities, so no, you should shield. So we're spending a lot of time trying to help people manage the risk, because obviously many people have to go back to work. Their bosses, their organizations have been told, yes, you can go back to work. So again, with Leukemia Care and the Alliance of Blood Cancers, we're trying to give advice, we're trying to give briefs that they can show their bosses about our type of cancer comes under the employment rights, and they can negotiate about home working, flexi working, what shielding, and some companies have been very good. Some educationists have put shielding and given special spaces for teachers going back. Others, nothing at all. So there's a lot of stress. And in fact, you know, the latest feedback we get is it's more stressful now than at the heart of the pandemic when everyone was shielding. So the plea we're making and trying to lobby government to do as well is mask. In the UK, you don't have to wear a mask. But in the debate I think I was on yesterday with Renata on there, she says research shows if you wear a decent mask, that cuts 95% of the danger of getting infection. So that's the plea I would put out there. So it's difficult times, certainly in the UK.
I'm just going to add one thing in this line. As the world opens up for the majority of people, it's closing up for us. Is we depend on the kindness of strangers. Other people wearing masks protect us. As that stopped globally, we're at higher danger, just echoing what Mark said.
Yes, indeed. One of the questions that have came from the audience is how do we take advantage with this focus on immune challenges to ensure that we do not remain excluded from society? Would you want to build up on that? Any of you?
I think the race and the pressure must be on research to find out what the evidence is for the vaccinations, the monoclonal ones that are coming out. What evidence is there that it will protect us? And until that data there, it's, you know, it's a bit of a crystal ball, even for the specialists to say, if you join society, you will be safe. You won't. As Brian says, the plea should be to shield when you're around people you know, people you love, people you care for, that have immunocompromised situations. My family know, my friends know, people I touch with charity work, I do know, but I have to check when I go to the supermarket because they don't know. And I'll get someone, I'll be reaching for something and someone will be leaning over my shoulder to grab something as well. On there, they won't be masked. So I don't think there's an easy answer you can give here. It's about managing the risk yourself and taking that call.
Indeed. And all these make me think about quality of life. Also, for instance, global health status, but also the worries about future, about health and functioning and mental health. And you mentioned that before. I think that was Leah. Raymond, could you share with us your feelings about these challenges on quality of life, mental health?
Well, I think a lot of good points have been made already, and by the panel, especially around COVID. And now that COVID is becoming endemic, I mean, we have to somehow change our mindset from this has been a COVID crisis to this is going to be our ongoing COVID reality. And if I could add to that, if we want to manage that reality better, we have to start thinking of getting people who are in other countries who have less access to vaccines to get them vaccinated. We were, you know, in Canada with the same thing. We're very focused on how many people were vaccinated in our country, and we're not really thinking about Africa, Asia, and all sorts of other places where people aren't vaccinated and where the virus continues to spread and continues to to mutate and continues to pose a threat. So I think we need to be thinking a bit about that, about the big global picture. About mental health, well, yeah, it's obviously a big issue, and everything that's been said, Leah, Mark, Brian, and others, really touches on that. Is how do we live our lives? And I think that we as patient groups we play a major role in that, in helping people, because one of the things that helps mental health is when you feel you have control over your life and you can make decisions and you're not prey to sort of unknown forces. And the one thing that helps you do that we can, as patient groups, help our members and do is with information. And so by providing information and tools and by empowering people to better navigate the medical system and what questions to ask the doctor and what are your rights as a patient and all those things, I think will give people a bit more feeling of control over their lives, and that and that will be beneficial to their mental health. So I think continuing to do what we've been doing and maybe trying to think about doing it better and with the optic of giving people control over their lives, that if they want to go out in the world, this is what you can do to protect yourself, for example, as opposed to staying at home, based on the risks you want to take. And also contextualizing the risks. I mean, we did a review this summer for our members. It's on our website about what the evidence was in terms of the risk of COVID to CLL patients, and in terms of the vaccination status, and then what they can do faced with the risk. And so putting these things in context can help people. How dangerous is COVID really? What are the consequences? Is it much more risky for me? Is it given my treatment status? So what do the studies say about the likelihood of me having antibodies or not, even if I don't get tested? So that kind of information can perhaps help empower people and take a bit of control over their lives a bit, and thereby helping their mental health.
I cannot agree more. Thanks for that. And
can I just add one thing about large A advocacy here? And this is that one of the things that I hear universally is governments, at least in the first world, in Europe and Western Europe and North America, declaring victory. We've got it. This is nipped in the butt. But they've left out all the immunocompromised. And we're not protected to that same extent. And so it's our job as advocacy organizations to shout and scream, look at us. And sadly, the tragic loss of Colin Powell in the US has cracked open a door for us that we've been leveraging to say, look, he didn't die because he was vaccinated. He died because you weren't vaccinated. He died because we don't have active agents at this point to protect people like him, another blood cancer patient. So that's another big issue that we have, is this, the governments want to get back to business as usual. And do they care about the 2.7% who are immunocompromised? No.
Endemic disease is not business as usual either. I mean, I agree with what you're saying, Brian. I think an additional argument is that the disease has now become endemic. It's around all the time, and that's not a victory. That's another problem we have to deal with in a different way, but it's certainly not a victory.
Yes, I wonder if, after this conference, I think this is not an isolated situation for CLL patients, but it's common to other blood cancer patients. So I wonder if we could organize ourselves to prepare kind of declaration and to use that for advocacy at global level. And I'm sure that if we join efforts, all the networks, and we have other external stakeholders that I'm sure will support us, we could try to campaign for having a strategy, but needs to be harmonized. Because otherwise, what we have learned from the pandemic is that no one is safe until everyone is safe. And thinking about this, I don't want to transform this panel discussion into a COVID panel discussion, because I know that the challenges go beyond. However, I want to take advantage of a few changes that were introduced or probably not introduced, but they cover more strength during the COVID pandemic as the use of technology or strategies to mitigate distance from patients to hospitals. A lot of services were moved close to the patients, even for clinical trials. But I wonder, how can CLL patients could mitigate distance and technology barriers to care now and in the near future? Because, I mean, digitalization of health is wonderful to support in-face appointments, however, is leaving a lot of patients behind. Anyone, who of you want to talk about this?
I don't think we should go back to, go ahead, Raymond, you go ahead.
Well, I'm not sure how relevant this is, but as a CLL patient, every 3 months I go to I've been treated and I follow up on the treatment. And every 3 months I go for a blood test and see my hematologist. I go to the hospital and he checks my lymph nodes and I'm out there and everything's fine. Fortunately, great news. But, I could go to the local health center right near my home and get that done there. And a nurse could check my lymph nodes. And if she sees a problem, and if she sees a problem in the blood test results, send me to the doctor. Even I could identify problems with my blood test results. That's another issue. But why do I have to keep going to my physician? So, and I expose myself going downtown, et cetera, where I could just go to a local center and get less exposure. I mean, that's one example I can think of.
One small silver lining from COVID is we've learned how much we can do digitally. And so I don't want clinical trials to go back to business as usual. I want people to make telehealth visits. I want there to be less having to travel to different places. It's a way to save money. There's a lot of, at least in the US, industrial push to get back to business as usual, because that's where the money's made, in the doctor's offices, in the hospitals, in those clinics. But we have to set up ways where the healthcare providers are adequately compensated for telemedicine. And in the US, telemedicine across state lines is a big issue. And so there's all kinds of questions here that we solve with COVID-19, and we're about to throw away those solutions for going forward, which makes absolutely no sense.
Thank you, Brian. But I wonder how it looks in other areas of the world, because I wonder, how is access to technology and how has worked digital health in your country, in Armenia, Yerevan?
We have a good internet access, but the situation is different from USA and other countries, because we have in Armenia only one hematology center, and even doctors afraid to check the lymph nodes. That's why all our patients should come to hematology center. We are cutting they are coming to hospital, maybe not so frequent like before, after this pandemic, but they should come 3 or 4 months after the first checking and continue the checking. That's why telemedicine couldn't solve all problems, surely.
Thank you, Yerevan. Yes, Mark?
I think maybe it's beholden to the Western countries to lead the way on some of the technologies and pass it down, the same as the vaccines we should be passing out to the rest of the world. In the UK, we're involved in the remote monitoring trial for chronic diseases, blood diseases. So people have an app on their phone, all the information will be on there. If they get any signs or symptoms that they want to tell their GP or the specialist, it'll be on there. They'll take the local bloods at their local surgery instead of going to the hospital centre, etc. And there's a great demand, there's a great interest. I asked for people to volunteer. We had 100 within 24 hours put their hands up to join the monitoring trial. So some of these technologies, some of these remote monitoring apps, we need to develop and then share out, part of the coalition, the collaboration.
Yeah. We have 10 minutes left, and I would like to talk about a few other things. Lislot, I know that you have been pretty interested in research in patient experience in general, and I would like to listen from you how you think that knowing more about the patient experience may help to increase quality of care or even resources allocation, efficiency, and patient outcomes.
Yes, I think that to really realize what value all new research brings to the patient perspective is very important. And when it comes to patient involvement in research, I think it's so important. And I was so happy when they brought that up in the medical session previous today, the things that they are doing in Oxford. I think that was so brilliant. And as a patient organization in Sweden, we have started a project that we mentioned, Patient Panel. And that is from an initiative from the UK, Patient and Public Involvement in research and in trials and whatever. So, and we have a fund that we funds research projects for, this is not for just for CLL, it's for all blood cancer. But from now on, we are putting a patient from the patient panel in all kinds of funds that, or all kinds of research projects that we are funded. There has to be a patient from the patient panel involved. And all the patients that are in the patient panels from now we have 15, they get educated in research, how to make research and how to make trials and so on. So I think for the payers and for the researchers and for everybody to really see what value all these new innovations brings to the patients, there has to be patients that are that really knows the condition. So yeah, I think.
Thank you. And when we talk about unmet needs, I mean, gaps and challenges, I cannot stop thinking about how race and ethnicity introduce some other barriers. For instance, we have listened that algorithms for clinical trials or even for treatments in general do not introduce discrimination by race or by ethnicity, however, may have different responses. But it's not only that, it's languages, beliefs, even cultural barriers. Jana, as you have been involved not only, I mean, in CLL Advocates Network, but in other many networks, and I'm conscious of your work in cancer in general at European level. I would love to listen from you how you see these disparities could be addressed.
There are disparities even locally, even within a country, not speaking of around Europe, and we are a global network. So for globally, this is for sure. But I think that the collaboration with medical societies is the first step towards this, to see how the standards are raised, appropriate care in different regions, and from that we can raise it to the global And I see here now there is some discussion in the chat about the vulnerable patients with regards to the rest of the population. So there should be some initiative together that we take together to raise this point, because this is not an issue that we can take on a smaller scale. We need a united voice, so to say.
And Leah, would you want to add something on this topic?
I was thinking while listening to Jana that even in a small country like Israel, and quite the same, we have discrepancies in places. Like, for instance, if you are in a big city, then you have better access to everything. You have better knowledge. You have less misknowledge, which is one of the things that are very disturbing now, that there is quite a lot of misknowledge going around, and people are relying on this misknowledge many times. And I was thinking what we can do, and I think it is our job to bring all the information and all the possibilities to the people which are not in the big centers, which are not treated by CLL experts, which have no access to very good treatments, just as everybody else. So I think spreading the information is our job.
Yeah, indeed. One of the comments from the audience is that we need to rethink how we support the CLL patient community and consider priority for several years ahead, and not just one day at a time, as the rest of society is doing as it opens up. And as we have only 5 minutes left, and there are a lot of learnings, of course, from this pandemic crisis, and I think we have to learn what we have done well, but also we need to learn from the vulnerabilities that have been exposed from the healthcare systems, from the patient advocacy, from the clinicians, the clinical practice as well. I would like to give you like a moment for one last reflection, and please try to build like headlines that could be topics for discussion for the near future. I will start with Mark.
I love an expression I've heard and I've used in life is, if you think knowledge is expensive, try ignorance. And it's really come to the forefront through the pandemic. So I think a lesson for us, and one I'm hearing from the debate here and other debates I've been involved in, is we need to work together to share knowledge, to leverage, to lobby and work as one. So collaboration for us, I think, is key going forward.
Raymond.
For me, very important, the idea that mentioned the Mark about some kind, and you mentioned, Natasha, about some declaration from our organization. Maybe we can join all patient organization, and the voice will be more powerful, because it's a big problem, especially for my country, and patient voice will be more powerful for them than sometimes a doctor voice.
Liselott?
Yes, I think it was a very good initiative that you proposed, Natasha, to bring all global organizations together, and just to make a submission or something to show and to just about the vulnerable patients with blood cancer, not only CLL patients actually, but CLL patients, of course, are one of the most vulnerable. I think this is really important when we are getting this COVID situation to an endemic situation. So And also, I just want to bring up again this patient involvement in research in HTA. I think this is so really important. So, yeah.
Leah?
I want to stress what Ryan has said before, very convincing, that we have to cement all the things that we have learned during this pandemic. Also in the time of the continuation of the pandemic, which is not over, as we all know, and even afterwards, there are a lot of tools that have been used because we didn't have any choice, but we can continue using them. And I think this is a very important thing not to forget.
Raymond.
Well, I would add that, we've talked about public awareness in terms of the continuing endemic, you could call it. I think knowledge, we need to remember that knowledge is important. There's so much we don't know about the immune system and how people react, and what science we can bring to bear in helping people to regain, immune-compromised people to regain control over their lives. That some additional knowledge there would be very, very helpful. And I think we need that as well, scientific knowledge.
And Jana?
Well, since this is the third day of the conference, and there has been so many interesting topics raised and so many new ideas, I would wish not to wait till the next conference, but to stay in touch on a more regular level, or just to cover the distances that are between us, to align on these topics and to work on them more, because not to leave them just as agenda points of an excellent conference which has happened, but to work on the priorities that we are all have a consensus on.
And Brian?
I think great discussion here, echoing on what Mark said about, I love that quote. Our motto is, the CLL Society has been smart patients get smart care, and we've got to work our way up, and we have to do small A advocacy. We've got to teach patients, that's our job as advocacy organizations, how to advocate for themselves in the doctor's office, in the clinics, in the hospitals. But what COVID has taught us, we also have to do large A advocacy. We have to advocate on an institutional level, and we're more powerful when we do that together. I would add one word of caution in. There's a difference that we're united with a lot of other immunocompromised communities, but there's huge differences in how people handle infections, and immunity is extraordinarily complicated. So I think we have a certain alliance with other blood cancers, but I'm a little worried to spread that to the entire immunocompromised community, because some of them do great with vaccines and are doing well, like the HIV community, very immunocompromised, but do great in the COVID era. So I think what we've learned here is we've got to pull together. We've got to make ourselves smart as advocates. We've got to advocate. We've got to teach the communities we serve to be smart for themselves as an individual. You got to take care of yourself first and make sure you're healthy and well and getting your best possible care, your best possible testing, the best possible treatments. And then you've got to move that to the larger governmental level, institutional levels, so that so it's not just you, but your fellow patients, the community, the large community you're serving, and those two are lockstep together. You can't do one without the other.
I want to thank all our panelists. I think that we have wonderful reflections and wonderful learnings from the conference. I just want to remember everybody that if you want to go fast, go alone. But if we, as patient advocates, I'm sure we all want to go far. We need to go together. And with this, I close this session. Thank you.
Thank you.
Thank you.